Welcome to the AUA Inside Tract Podcast. Today's Inside Tract Podcast is part of the Meet the Subspecialties series and is brought to you by the Residents and Fellows Committee. Dr. Rachel Mann, urology resident at the University of Minnesota Medical School, sits down with Dr. Joseph Pariser, assistant professor of urology at the University of Minnesota in Minneapolis, to explore the subspecialty of genito-urinary reconstructive surgery.
Hi, everyone. Welcome to the AUA Inside Tract Podcast channel. Today on the Meet the Subspecialties series, we are talking about genito-urinary reconstructive surgery. I am Rachel Mann. I'm a chief resident at the University of Minnesota. I am pursuing a GURS fellowship myself at the Leahy Clinic next year. And today I'm talking with Dr. Joe Pariser. He is an assistant professor at the University of Minnesota. He did medical school and residency at the University of Chicago, and then a combined fellowship with Dr. Rick Santucci and Dr. Sean Elliott. His current practice is a nice mix of transgender surgery, urethral reconstruction, and robotic upper tract reconstruction. He also actually helped build the multidisciplinary transgender clinic at the University of Minnesota. So welcome, Dr. Pariser.
Thank you for having me.
Yeah. So I'll kind of dive right into it. I want to start pretty generally, what made you decide to pursue reconstructive surgery? Sort of how did you learn about the field? What cases did you like in residency that may have inspired your choice?
Yeah, thanks for the good questions. So I started in urology because I like hands-on field with a nice mix of cases, a good group of people, and interesting subject matter. In urology residency, we had a lot of oncology, robotics, open surgery, but we also had an excellent reconstructive program at the University of Chicago, which was led by Greg Bales, who just recently retired. And he really honed a love for reconstruction, figuring out cases, thinking critically, using all possible options. And he really let the residents take ownership of the patients. And I found myself thriving and really loving all aspects of reconstructive urology, which is a nice field where you get to help patients and craft personalized plans for a lot of patients who've been turned away elsewhere.
Were there any specific cases in residency that you found yourself gravitating toward, anything open, or did you like robotic? Did you like all of it?
I mean, to be perfectly honest, I liked almost all of residency. Most of robotic skills for residents are learned from oncologic cases like robotic prostatectomies or nephrectomies. But I really thought the part of urology that married technical aspects with formulating personalized plans was in reconstruction. Some of those cases, for example, would be urethroplasty, fistula repairs, cystectomies for sort of end stage benign conditions. I also really like genitoplastic procedures, meaning surgeries on the external genitalia. And I always really like buried penis repairs and other sort of surgeries like that, really changed people's lives for the better. And some of the results were sort of instantly noticeable on the outside of someone's body.
It sounds like you're just a pretty creative guy overall. Were you always like that?
I would not say creativity is naturally my skill. For example, I'm not a great fiction writer or artist, for example. I am a very good editor. And perhaps since I'm not building a human from scratch, I'm editing someone's body, then that actually fits my skill set more.
That's pretty interesting. Can you tell our audience sort of what is a typical week for you? What are your hours? What is your case mix? What does your clinic look like?
Yeah, so I really have a very focused reconstructive practice. But in reconstruction, it's a huge mix of cases. So my typical week is 3 days in the operating room and about a day and a half a week of clinic, and then a half day of administrative catch up or meetings. A typical mix of cases would be, so for example, This week is a pretty typical week for me. On Monday, I did a robotic ureter repair and then a revised a phalloplasty complication. Tuesday and Wednesday is a day and a half a week of clinic. Tuesday's clinic is devoted to gender affirming care, and Wednesday's clinic is a mix of all reconstructive urology issues. Thursday, we're doing a full depth gender affirming vaginoplasty, and then Friday is a variety of cases at our outpatient surgery center. So that's a pretty typical week.
I know you go to also a children's hospital here in the area, Gillette Children's Hospital, and you do some work there. Can you talk to us about that?
Yeah, so Dr. Elliott, one of my mentors, and I share a clinic at an outreach hospital called Gillette Lifetime, where adults with congenital issues like spina bifida, cerebral palsy, and a wide variety of other conditions come for their care. Congenital urology is also an exciting field where a lot of patients don't know and don't have a great home for their ongoing urologic care. Historically, a lot of patients who had pediatric reconstructive surgeries didn't live as long, to be perfectly honest, and so they didn't need as much ongoing care as adults. But we have a huge population of these patients, and Gillette Lifetime is a nice place where they can see a number of specialties, including urology or neurosurgery or physical therapy or occupational therapy or a number of other things. So we do an outreach clinic a few times a month between the two of us.
So you have a pretty diverse case mix in your practice. A little bit of neurogenic bladder, a little bit of transitional urology, some general recon, and then a lot of transgender surgery. Can you talk about your interest in trans surgery? So neither of your fellowships actually covered this as a subspecialty within reconstructive urology. Is that right? How did you learn this? How did these skills come about?
Well, we had a decent amount of gender affirmation happening where I trained in residency at University of Chicago. And so we would see a number of phalloplasty complications or other surgeries like that, penile prosthesis in phalloplasty or urethroplasty in phalloplasty. And I started my interest with getting involved in some of the research projects. If you dig deep into my CV, you'll find some publications on erectile implantations or urethroplasty and phalloplasty. And so taking care of those patients and seeing what they went through and really trying to piece their story together and crafting up personalized surgical plans was pretty satisfying in residency. We did do a handful of other revisions throughout my fellowships. I got more interested in gender affirming surgery when I started thinking about a faculty job, and my leading faculty job was at the University of Minnesota, where I happened to land. And when I was interviewing here, they had just recently hired a plastic surgeon who had spent a month-long mini fellowship in Belgium at one of a big gender affirmation surgery practice. And he was coming back as a plastic surgeon, a microsurgeon, and wanted a urologic surgeon to basically split the surgeries and do the surgeries together. And I knew, given my various training places, knack for pelvic anatomy, genitoplastics, and some experience in the transgender community, I thought I'd be a good fit. And so that's how I got into it.
And you actually helped start this multidisciplinary transgender clinic at the University of Minnesota. So, the University of Minnesota is a huge transgender referral center in the Midwest, in the upper Midwest especially. Talk to us about what that was like, opening up this multidisciplinary center. What different disciplines are involved? I am getting similarities from this outreach clinic at Gillette to this transgender clinic we have at Minnesota. Can you talk about sort of what was involved in opening this?
Yeah, so when I started here, there were a variety of options or providers or surgeons for different aspects. For example, breast surgery was commonly performed at the U of M. And historically, there actually were some genital surgeries being performed. When I joined, one of my partners was doing orchiectomies, and another one of my partners was intermittently doing minor revisions for post gender affirmation surgery patients. And there was a huge center called the Center for Sexual Health, which has now been renamed, where a lot of the foundational WPATH guidelines and things like that had been crafted by a very well-known psychologist, a researcher, Eli Coleman. So anyway, there was a push to sort of conglomerate these services under the Center for Gender Care. We even discussed, and so there was a set of many meetings discussing who went where, what the leadership was going to look like, what we're even going to be called, how were we going to pursue more surgery, what was our online presence going to be, what were key people we would need to hire, would we physically be in a building, do we do clinics together, these sorts of things. And I can tell you from being in some of these meetings, having never built something like this before, it's a really slow process that takes months and months and months, and you kind of inch along towards a future goal. So you can imagine for a surgeon who's used to very immediate results, it's not my natural skill set to think like that. But on the other hand, it's extremely gratifying now, many years into the process, having a pretty good sized staff and having a high volume center.
And you have everything from like social work presence to plastics to surgeons to hair removal. Is that right? I mean,
yeah. So our gender center has gone through a few transformations. My partner, the plastic surgeon, left. So now I do vaginoplasties, with residents and fellows, but as the only attending surgeon. And then our facial feminization surgeon also left. But we currently have an intake coordinator who calls you back and arranges that sort of thing. We have a social worker who's also a therapist. We have a dedicated RN nurse care coordinator for the gender care center, in addition to our standard urology RN care coordinator and the plastics care coordinators. We're actively hiring, and we have ongoing interviews for APP, or nurse practitioner PA, for the gender care center. We're talking about things like billing people, prior auth people. The dermatology department runs a hair removal clinic, and they're always full with a big wait list for laser hair removal, which is generally a requirement before vaginoplasty, for example.
It's pretty amazing that you were part of building that from the ground up. That's right. That takes a lot. I want to switch gears here and talk a little bit about your research. So you are, for the people who don't know you yet, you're essentially a rising star in reconstructive urology. You've published over 60 publications. You have, many research presentations. You're invited to write review articles. Talk to us a little bit about sort of what research you've been doing lately. The University of Minnesota is also part of this Trauma and Urologic Reconstructive Network of Surgeons, or the TURNS network. Talk to us about sort of the reconstructive research that's out there right now, and specifically what you do.
Yeah, so research is a big part of reconstructive urology, and that can come in the form of basic science. Historically, not that many full-time surgeons do basic science, but a lot of our reconstructive procedures lend themselves well to outcomes research or comparative outcomes research. So I've been involved in a number of different project kind of formats. One of my research topics is in conjunction with my partner, Dr. Elliott, regarding our work at Gillette and neurogenic bladder, and some of the procedures to reconstruct bladders or manage those patients is pretty novel, and there aren't that many people doing that work, so people are interested. So that's a whole wing of our research. I also, because of our work in gender affirmation surgery, routinely am asked to contribute articles or publish our outcomes regarding vaginoplasties, how we do them, how we manage complications, phalloplasties, how we do them, how we manage complications, because while they're being done increasingly more, They have not been historically done in the most academic centers with outcomes being published, especially in the US. So those are kind of ripe places to do research. University of Minnesota is part of the TURNS research group, which is probably the premier multidisciplinary group of reconstructive urologic surgeons around the country. And that's a nice database and group that publishes on urethroplasty outcomes, artificial sphincter outcomes, and some other procedures. We're also part of the neurogenic bladder research group. That's part of that neurogenic bladder research that we were talking about before.
That's great. So, I mean, in addition to being a clinician, a researcher, also a big part of your practice is this fellowship. And I want to talk to you a little bit about that. You are an associate director of the GURS Fellowship at the University of Minnesota. Can you talk to us about that, about your experience being associate director, what you get out of it, specifically the fellowship at the University of Minnesota?
Yeah, so Dr. Elliott started the fellowship at the University of Minnesota. GURS fellowships were few and far between back in the day. 20 years ago, there was just a handful of centers around the country who would train reconstructive urologists. There's been a growth as those people have started their own fellowships. So when I applied, there was 12 fellowships or so. Now there's more like 20. When I finished the fellowship with Dr. Elliott, I joined on as faculty and have had the pleasure to train. I think we're on to I'm on to my 5th fellow currently, and I think Dr. Elliott has probably double that now. Every year we select one graduating resident from around the country, and that person is already a urologist and wants to do one more year of clinical training. And we really pride ourselves on selecting someone who really wants to push the field forward and is interested in the very diverse fellowship that we run in the corners of reconstruction. While we certainly do cover the mainstays of reconstructive urology like urethroplasty and prosthetics, I think the unique part of our fellowship is abdominal reconstruction, robotic surgery, gender affirmation surgery, and neurogenic bladder. So you come out from this fellowship really uniquely posed to handle a lot of surgeries that probably most centers around the country don't have even one person who knows how to manage. But certainly, even if there is a person managing that stuff or some of that stuff, you can add to that person's practice. In the 4 prior fellows, all are at major that I've helped train, all are at major academic centers, and some of those people are training their own fellows. So it's been really satisfying to not only train future stars, but future colleagues. And it pushes you to really be excellent when you're trying to train other excellent people.
And what advice would you give to a resident considering applying to the GURS match or another reconstructive fellowship, perhaps a non-GURS reconstructive fellowship? And I know personally from just going through the GURS match process that the fellowship at Minnesota is unique, but kind of the beauty of the GURS fellowship or these reconstructive fellowships in general is that they are all so different. You can really personalize the experience you get after residency based on which program you choose.
I would agree. The fellowships have become remarkably different as the number of fellowships have grown. Some of them really focus on urethra as much as possible. Some have a very, very strong prosthetics bent. Some of them do nearly no robotic surgery. Some of them include some infertility or female urology. And some of them are very focused on gender affirmation surgery, for example. And you can see how a resident choosing those might end up after a fellowship with very different skill sets based on which fellowship they choose. And I forgot to mention trauma is also a pretty big focus of some of the fellowships. So my advice would be, it helps to get yourself immersed in research early. It doesn't have to be reconstruction. It can be other research in oncology, or even, if you don't have reconstructive research, I, for example, published a lot on cystectomy outcomes and management of post-conduit complications. And actually, a lot of that stuff is still relevant in my practice today, which is helpful. Also going to society meetings when you're at the AUA is really helpful. I actually figured out kind of early that I like to be in the GURS meeting, not the SUO meeting at the AUA, both for personality, my clinical interests. It just seemed like the right fit for me. There are some other great options out there for experiences, whether that's traveling to other programs, or Cleveland Clinic runs a NERP preceptorship, which is excellent, that you can travel to and listen to days worth of lectures and really learn about different parts of reconstructive urology. Maybe you didn't have at your program, or maybe you've just never heard it in a structured way. And that's really helpful. I think people run into trouble when they think about fellowship, when they decide very late, like 2 months before the application opens. And you can tell those people because their interest isn't solidified, or they don't really have any projects ongoing for research, or their application comes in late. It is, every place has their own timetable, but I think doing some of the things early on and just kind of like building a gender surgery center, setting a long-term goal, kind of doesn't have to be the first week of residency or anything, but a couple years into residency, understanding what you're interested in and working towards that goal, you can build a nice case for your application if you have a few years.
That's awesome. I would agree with you on all points. Thank you so much for talking to us. I think this was really informative, and I appreciate your time.
Well, thank you very much for having me and the opportunity to talk about my interest, field, career, and
life.
Yeah.
Great.
This has been an AUA Inside Tract podcast brought to you by the Residents and Fellows Committee. Check out the AUA University podcast for weekly episodes on the latest clinical updates and advances in urology. For more information about the AUA and membership, visit auanet.org.